I will introduce our next speakers. We have Dr. Lenti. Dr. Lenti is an assistant professor of clinical medicine at the University of Washington, and she was outpatient chief resident last year, and she currently works at both our GIMC clinic, General Internal Medicine Clinic, and our OB/GYN Primary Care Clinic. And then Dr. Lenti is also going to speak, and you might recognize who he is. So let me just get this pulled up here. All right, thanks, Nina. We're just going to keep the fun going from Dr. Paul's studies, more updates. These are specifically outpatient articles that changed our practice that came out here in 2025. We have no disclosures. And after looking at the studies that we thought were impactful here in 2025, we kind of loosely categorize them into women's health, cardiovascular disease, and a couple of other studies. If you guys went to the pre-course yesterday with women's health, you might see a couple of studies that are familiar here. So like Doug, we also have some questions. You guys can go ahead and open up your app here and answer these. So first question here. Your patient presents for a visit for vaginal discharge. Workup reveals a vaginal pH of 5, a positive amine test, and clue cells on microscopy, consistent with BV. This is her third recurrence of BV this year. She is monogamous with one male partner, and she asks about the most effective treatment for recurrent BV. What do you recommend? Treat your patient with oral metronidazole. Treat your patient with intravaginal metronidazole. Treat your patient and her partner with oral metronidazole. Treat your patient and her partner with oral metronidazole. Her partner with topical clindamycin, or treat both your patient and partner with oral metronidazole, plus treat your patient with vaginal clindamycin. Okay, we've got a bit of a mix here. All right, we can go back to the slides. All right, so this was a new study that came out in the journal in March of this past year. It was a study done in Australia. It was a CT with 164 couples initially enrolled. The population studied here was women with bacterial vaginosis. They were symptomatic and specifically had to have 3 out of the 4 ANSL criteria, which is vaginal discharge, positive amine test, a vaginal pH greater than 4.5, and clue cells on microscopy. They also had to have a monogamous male partner for at least 8 weeks before enrolling in the study. The intervention group here was then treating the patient and her male partner. And this is what was unique about this study, is the male partner was treated with metronidazole and topical clindamycin. The topical was something that hasn't really been studied in the past. And then this was compared to the control, which was a standard of care, just treating the woman alone. They ultimately measured recurrent BV at 12 weeks, and this trial was actually stopped early after just 150 couples had completed the treatment because the standard of care was inferior to the intervention group, with BV recurring in 35% of women in the 1+ part of the treatment versus 63% of women in the women-only arm. Adverse effects were minimal in this case. The partner occasionally had nausea, metallic taste in their mouth, and headaches, which are common side effects of oral metronidazole. Not many side effects from the topical clindamycin. And so going back to our question here, the correct answer is probably D in this case, treating the patient plus her partner with plus topical clindamycin. And this is a practice-changing update here. I have done this in clinic. And then for what it's worth, the American College of Gynecology just came out with a clinical practice update that says, do this. And you can actually use your decision-making patients who are outside of this, who was studied in the study that came in March. You share decision-making in patients with same-sex partners or in their first occurrence of bacterial vaginosis. Also in this ACOG clinical practice update, they recommended that we encourage the male partners to get treatment from the rather than doing something like therapy. Okay, next question here. 55-year-old female patient presents for a visit following a DEXA scan. A DEXA scan was obtained at this age, given her strong family history of osteoporosis. Her T-scores were -1.5, -1.7, and -1.5. 5 at the lumbar spine, hip, and femoral neck, respectively. FRAX score was negative, or so was 1.3% at the hip and 9% for major osteoporotic fracture. Given her family history, she's really concerned about her fracture risk. You offer to her. No treatment, continue current management, and follow up DEXA in 5 years. Start oral zoledronate and plan to continue that for 3 to 5 years. One dose of zoledronate now, and then repeat DEXA in 5 years, or give her a dose of zoledronate now, and then do it again in 5 years. Okay, looks like most people are saying continue the current regimen. And glide back to the slides. Okay, so moving along here, this question is based off of a study that came out in January of this past year, also published in the New England Journal. This was a prospective double-blind RCT that was conducted in New Zealand. They randomized just over 1,000 postmenopausal patients, so specifically 50 to 60-year-old women without osteoporosis, so a bone density of 0 to negative 2.5. This was a prospective trial, as I mentioned, and the interventions, as you can see, there were 3 arms. Patients were either treated with zoledronate at baseline and then again at 5 years, zoledronate at baseline, then placebo at 5 years, or placebo twice. All of the endpoints were assessed at 10 years. The primary endpoint in this case was morphometric vertebral fracture, and this was at least a 20% height loss when comparing baseline radiographs, spinal radiographs to the 10-year radiographs. And as you can see, the morphometric vertebral fracture was 6.3% in the ZZ group, 6.6% in the ZP group, and 11% in the placebo group. It was significant comparing the 2 doses of zoledronate compared to the placebo group. But I think that the more salient statistic here is that bottom point, that the number to treat to prevent one woman from having a new morphometric vertebral fracture was 21, getting 2 doses of zoledronate, actually 22 for getting zoledronate and then placebo at 5 years. Now, you may be wondering, is this actually clinically relevant, this morphometric vertebral fracture that they measured? And they also had secondary endpoints that looked at actual fracture risk. Without going through all of these different secondary endpoints that they studied, there was a lower risk of any fracture type in both the zoledronate group and in the zoledronate placebo group compared to placebo alone. So going back to our question, I agree with you. There's not totally the answer here, and you probably could. Most people. That said, I think I would have definitely offered A before the study came out. Actually, might have conversations with patients about options C and D, offering zoledronate earlier on for early postmenopausal women. And I like the way that the study phrased it, is that if patients who are early in their postmenopausal phase wants to reduce their fracture risk, they could consider a strategy with infrequent zoledronate dosing. And because zoledronate is generic and low cost and may be administering it pretty infrequently, it actually might be cost effective for the individual and for systems. Although with the caveat being that it may or may not be approved by insurance. Okay, next question here. We're discussing cervical cancer screening with a 31-year-old transgender male patient. Patient has a vagina and a cervix, and they have not had any prior cervical cancer screening. Currently sexually active with one female partner, but they have had vaginal intercourse with male partners in the past, and they prefer to avoid pelvic exams due to a history of trauma. What do you recommend? Defer cervical cancer screening, given the preference to avoid pelvic exams and the patient being generally low risk. HPV self-swab, and if negative, follow up in 3 years. HPV self-swab now, and if negative, follow up in 5 years. Or just go ahead and do that clinician-performed pap smear. All right, we're thinking about self-swabs, but wondering about when we should be following up for this patient. Okay, we can go back to the slides. Okay, so a couple of studies came out in 2025 regarding self-collection for cervical cancer screening. And this was an interesting study that came out, I think it was June of 2025, published in JAMA. This was a pragmatic, single-blinded RCT out of a safety net hospital in Houston. They had just about 2,500 participants in the intention to screen analysis. And these were specifically patients who were under-screened for cervical cancer, so either did not have cervical cancer screening prior or were due for cervical cancer screening, were 30 to 65 years old, and specifically did not have a history of cervical dysplasia in the past. These participants were then randomized to either receive just a telephone reminder telling them to come into clinic to get their pap smear done, or in the intervention arms, receiving that telephone plus a self-collection kit for cervical cancer screening. And then in the third arm, you could see they received both the telephone reminder, the self-collection kit, plus a call after receiving that, which they called patient navigation. In the chart there on the right, you can see that the cervical cancer screening participation rates compared to just the telephone reminders alone. And so overall, sending out these self-collection kits was more effective than just the telephone reminders alone. And those people who were mailed the self-collection kit, 80% did the self-collection kit rather than coming in person for the cervical cancer screening. Also came out in 2025 is our consensus guidelines for self-swab HPV cervical cancer screening. This might be for some people. People self-swabs were FDA about physical activity. You shared that there was a recent study that shows you can lower your blood pressure slightly by reducing the amount of time you spend sitting down, increasing the amount of time you go from sitting down to standing up.
Nobody's turfing the cardiologist. I'm proud of y'all. Okay, well, it's not going to be a good day for aspirin. Thanks, we can switch back to the slides. So, as you should know, because Doug literally just told you, most patients post-PCI, so post-intervention, get dual antiplatelet therapy for some length of time. That length of time, the data keep going back and forth. It seems like most of the time they're getting it for 6 to 12 months. There is some evidence suggesting 3. I will tell you as a primary care doctor, I do not go to war with the cardiologist over this because the patient wants to take it for exactly as long as the cardiologist says, and the cardiologist wants to give it for exactly as long as the cardiologist says. So in that immediate post-stent period, I'm not doing a lot of fighting unless it goes past a year, at which point you're getting crazy. But 3, 6, 12, I can work with that. What's interesting is in the post-DAPT period, what happens? Because it seems like, as 50% of you said, a lot of people get left on aspirin. And there have been compelling data that the P2Y12 inhibitors, particularly clopidogrel is the best studied, are both safer and more effective for these patients for long-term maintenance of their antiplatelet therapy than aspirin. And this just has huge clinical inertia because some of these data are old. This one is new, that's why I put it in for this year. And what it showed was a 2.2% absolute reduction in a composite cardiovascular endpoint of CV, MI, and stroke over 3 years. So for every 137 people you kept them on clopidogrel instead of keeping them on aspirin, you had a reduction in that endpoint with no difference in bleeding. One thing that was interesting about this is that the study was done in Korea, and there is a particular cytochrome P450, which is more prevalent in people of East Asian descent, that decreases clopidogrel metabolism. So they actually looked at that. A quarter of their cohort had that P450 allele, variant. And they didn't see any difference in outcome in that population either. The study wasn't designed specifically to look at that, but it's very reassuring to me because I've always had that in the back of my mind. Are there going to be some people who don't metabolize clopidogrel well? It didn't make a difference in this study. So The right answer for this one is to stop dual antiplatelet therapy and continue clopidogrel. And I think this is home turf for all of us primary care doctors. We should feel comfortable doing this. Thankfully, clopidogrel is now relatively cheap. Looking at other aspirin things, so I just showed you clopidogrel versus aspirin post PCI, and that's a no. It's also been studied versus apixaban for subclinical AFib, and that's also a no. So pretty much anyone you're thinking, maybe I shouldn't put them on aspirin for their AFib, you should probably be putting them on a DOAC. Versus clopidogrel for secondary prevention post-MI, even if they didn't get a stent, that's also better. Clopidogrel is better than aspirin, even in people who didn't have an intervention. Those are super old data, and it's still really hard for even me to be like, I know these numbers, it's hard for me to do this. We should just be doing that. For stroke TIA, better to stick with clopidogrel than aspirin once they finish that initial short window dual antiplatelet therapy for that. Versus placebo, this is aspirin versus placebo, not versus clopidogrel. In older patients, no, no, no. There's multiple studies showing that over the age of 70, the risk of things like primarily GI bleeding, but all the badness that goes with aspirin goes up, and the risk of benefit stays flat. So not for those people. Versus placebo for secondary prevention of colon cancer with a specific mutation, yes. I thought this was interesting, wasn't worth its own slide, but there was a study that came out in the New England Journal. People whose cancers, when they were removed, had a PI3K mutation, did dramatically better on aspirin, like a 25% reduction in recurrence. And this was the Alaska study, but they were in Sweden. I don't know what they're poaching my home state. This I found really interesting because there was a study many years ago that actually looked at aspirin and colon cancer prevention and found a very small effect across the whole group, but when they did a subgroup analysis, they found that it was actually a large impact in a small number of people. This helps us understand the biology better. I would expect for those of you who practice primary care that people are going to hopefully come back from their oncologist on this, because I'm not always looking at the path report for the PI3K mutation. But if you are either looking at that path report or you're seeing people who've had treated colon cancer coming to you on aspirin, it's a thing. The one place where this is still kind of unclear, and Doug alluded to this as well, is if you have a patient who is younger and at high risk, or if you have a patient with secondary prevention, should you be using aspirin at all, or should you be thinking about clopidogrel? And that's just all kind of muddy right now. So the bottom line is, for most people who are taking aspirin as antiplatelet monotherapy, we probably should be looking for something better. But if they got colon cancer, hey, maybe it's great. Okay, 54-year-old male patient with type 2 diabetes comes in for follow-up. Medications include metformin, dapagliflozin, atorvastatin, losartan, and losartan 50 milligrams. Exam shows his blood pressure is 136/80, pulse is 78, BMI is 27. Recent A1C was 5.9, LDL was 60, albumin-creatinine ratio was good. So what do you want to do next? A, increase losartan to 100 milligrams. B, add tirzepatide. C, add amlodipine 5 milligrams. D, don't mess with success. Ooh, all over the map. For those of you who chose the GLP-1, I gotcha. All right, right answer here is going to be one of the blood pressure meds, and let me come back to which one and why. Thank you. Wow, that was sweet, man. Nice timing. Okay, so this is a study called BP Road. Again, this is one of these things that's reaching back. I find when you get older, you start remembering, oh yeah, there was a study on this before. But this is an actually important study. This was a cohort in 2010, and they studied intensive blood pressure management in patients with diabetes, and it was a negative study. It had a trend towards a difference, but it did not have a significant difference. This kind of popped up again 5 years later when the SPRINT study came out, which actually was a practice-changing study because it was done in patients without diabetes, but with high cardiovascular risk, did have a positive result, and that was the point where we're like, well, we should probably start pushing people below 120. But this question of what to do with patients with diabetes was kind of still floating around out there because they were excluded from the SPRINT study because of the negative result in the ACCORD. So someone finally went out and did a bigger study trying to ask was the problem with the ACCORD was it just too small? And you see this was a 3 times as large study as ACCORD, and sure enough, that was the problem. So this was randomizing people to either trying to get their blood pressure below 120 versus below 140. It was a 4.2 years of follow-up, and for every 227 people where you targeted a more intensive target, you prevented one of that composite endpoint of cardiovascular death, stroke, heart MI, and heart failure. So pretty good signal that we should be treating people with diabetes and without diabetes but high cardiovascular risk to less than 120 if we can get there. As you would expect, higher rates of symptomatic hypotension, which, you're pushing their blood pressure lower, go figure, but it wasn't super common. It was interesting that in this study there were higher rates of hyperkalemia. In SPRINT it was hypokalemia, which makes me wonder if one study was leaning on the ACE-ARB and one study was leaning on the diuretics more. I'm not sure. The one caveat I would have with this study is they actually allowed people in the non-intervention arm, in the control arm, they allowed people to unload blood pressure meds if their blood pressure was less than 130. So that's not what I would normally do. So that may have exaggerated the treatment effect a little bit, but nonetheless, I think trying to get people below 120 is the right answer. So that's one piece of this, but we're not all the way to the answer to that question yet because we had 2 antihypertensives on it. So this is the other thing. Now, this is a colorful slide where, you can't even see the words very well. But what you're looking at here, hopefully this will come through a little better in the handout, is on the left-hand side you have 2 meds, hydrochlorothiazide and amlodipine, and on the other axis you have various add-on meds, losartan, lisinopril, and metoprolol. I will translate for you the bottom line from this slide because I love this table and it came out of the article. Basically, you get twice as much impact from adding a low dose of a new drug as you do from doubling the old drug. I'm seeing some nods out there. I think people who have been in practice a while, this is not surprising. It is nice to see it finally studied and on paper. I like this one partly because it had the table and partly because it combined 400 trials and 100,000 people to come to this result. So it's very robust data. Obviously, 3 drugs is even more potent than 2. Maybe that's not obvious. So for me, the practice-changing thing here is, for a long time I was like, you can kind of do whatever, and sometimes I would lean towards increasing the dose of one drug rather than going with 2 simply because it's simpler. If you really want to get it done, it's probably better to go with lower doses of multiple drugs, and obviously I selectively choose ones that can later be put into one pill if that's feasible, but that's just going to work better in terms of your outcomes and probably have equivalent side effects. So for this particular question, I would say it's probably better to add amlodipine because you're going to get, you want to get from 136 down below 120. You're probably better to add amlodipine. You're more likely to get there with a new drug at a lower dose than simply by doubling losartan. Okay, one more. 47-year-old male patient with prior unprovoked leg DVT comes in for follow-up. 3 months ago, he decided to continue rivaroxaban indefinitely, has now been on 20 milligrams daily for 6 months. He would like to have the best balance of recurrent thrombosis and bleeding risk. His exam shows a blood pressure of 122/78, pulse of 84, BMI of 28. There's no edema or post-phlebitic changes in the leg. So what do you recommend? Do you say, stop the rivaroxaban and start aspirin, cut rivaroxaban down to 10, switch to apixaban at 2.5 milligrams twice a day, or just stay on the dose of rivaroxaban that he's on now? Mixing it up. Okay, we got some cut rivaroxaban, some continue, some switch. Okay, I like this. This is good. Oh, wow, change real quick. Okay. All right, let's talk about this one. So this was a study of dose-reduced treatment in unprovoked DVT, and these are the people where remember, I know I'm harping on something that we all know, but people who have a first unprovoked DVT have the same risk of recurrence as people who have known risk factors. So this is why we don't go crazy with workups for things like factor V Leiden, because if you have it, you have a bad risk. If you don't have it, you still have a bad risk. So unprovoked DVT is a bad thing. Whenever you stop their anticoagulation, that risk goes back up. So the question as to how long people should be on anticoagulation is pretty much, if you can do it for as long as you possibly can, that is the right answer. So this was not about how long, this was about what dose. And they randomized people to either continue their standard dose or drop to half the dose. And they actually used both apixaban and rivaroxaban. It was an open label study, so it wasn't exactly like the cleanest study in the universe, but it still had a pretty convincing outcome, which is that for either drug, half the dose was basically equivalently effective. You can see that top graph is the risk of recurrent venous thromboembolism. There's a tiny, tiny increase in the low dose group, but significantly lower bleeding rates in the lower dose group. So based on this one, there was interestingly another study in cancer patients that showed the same thing. So based on this study, I think you could choose either of these. From my point of view, if I'm going to put someone on something basically forever, I would much rather it be a once daily drug. So if they're on rivaroxaban, they're tolerating it, I would stick with that. But if you really like apixaban and BID drugs, you can do that too. That's the take home. All right, back to you.
All right, I think we have 5 more minutes left, just enough for a couple of grab bag studies. Anything else? A couple of points on MASH. A couple of studies came out on MASH this year. I feel like we went from having nothing to treat MASH to actually now a handful of things that can be effective for treating metabolic dysfunction-associated steatohepatitis. This was a study that came on June of this past year for semaglutide. This was a really huge study, phase 3 multi-center placebo-controlled double-blinded RCT, over 30 countries, over 250 clinical sites, I think. And this was actually an interim analysis of the first 800 patients that were enrolled. And these patients had biopsy-defined MASH and fibrosis stages 2 or 3. The intervention was weekly semaglutide, ideally at the highest dose if patients could tolerate it, for 72 weeks, so a year and a half. The measures here, the outcomes were resolution of steatohepatitis and reduction in liver fibrosis. Both of these are endpoints that are assessed by a pathologist. Specifically, that resolution in steatohepatitis uses something called the NASH activity score, or the NAS. The results of the study were positive for both of these things, and so the semaglutide group had more resolution of steatohepatitis, 62% compared to 34% in the placebo group, and then the semaglutide group also had more reduction in liver fibrosis, 36.8% compared to 22.4%. So semaglutide, practice-changing update. This joins the likes of tirzepatide and other GLP-1s for management of metabolic-associated steatohepatitis, particularly in patients with higher fibrosis stages. So again, like the HFpEF study that Chris had talked about, this is another thing to go to bat to insurance for patients to be on those GLP-1s. And then interestingly, also in June of 2025, a non-GLP-1 study that contributed to the literature on what we can use to treat patients with MASH. And this was also a multi-center placebo-controlled double-blind RCT, except for this study was only in China, and it was a little bit smaller, 154 adults, also with biopsy-defined MASH. And this was in patients both with and without type 2 diabetes. The intervention in this case was 10 milligrams of dapagliflozin versus placebo, and this was for a year, so 48 weeks. Primary measure in this case was also a little bit different. They measured MASH improvement, and the improvement, as I mentioned, that NAS score, the NAS score, which is a score that is calculated by a pathologist assessing the hepatocellular tissue. What this showed was that MASH improvement was positive, with MASH improvement happening in 53% of the dapagliflozin group and 30% of the placebo group. Now, you may be wondering about MASH resolution after I told you about that semaglutide study, and they did study that as well. That was their secondary outcome. And they also showed that the dapagliflozin group had increased MASH resolution 23% compared to 8% in the placebo, and also had fibrosis improvement with 45% of the dapagliflozin group and 20% of the placebo group. So, dapagliflozin also joins the likes of the GLP-1s for management of metabolic-associated steatohepatitis, even in folks who do not have type 2 diabetes. Where'd you go?
This one's mine. This one is about an injectable medication for pre-exposure prophylaxis for HIV. The trial I'm telling you about is one of 3,265 cis men and then trans and non-binary people who are over 16 who, to get enrolled in the study, they had to say that they had condomless receptive anal sex. This was a global study. It was about 20% in the United States and had a pretty wide ethnic distribution, so nice large population. In 1 year of follow-up, there were 2 HIV infections in the intervention group versus 9 in the Truvada control, so that was an 89% risk reduction. The number needed to treat of 120. My take home from this is stuff is amazing, and it's much easier to do than daily PrEP. There was a study on cis women that was conducted in Uganda. It's lower quality data, probably largely because taking oral PrEP is really stigmatized in that country, so they didn't have great adherence, but it still showed a similar result. The catch with this is it's somewhere in the neighborhood of $20,000 to $40,000 a year. So this is, again, one of these things where if you can get it for a patient, and particularly patients who are at very high risk or who you have concerns about their ability to take daily PrEP, it's a game changer. It's just a question of actually getting it. And then one more, these are a couple of interesting studies about a blood test for Alzheimer's. And the question that I was asking when I was reading these is which patients with mild cognitive impairment need further workup for Alzheimer's? So this one was a study of 512 patients with a mix of dementia, mild cognitive impairment, and impact cognition. And what it did is it compared the blood test result to the results of an amyloid PET scan as the gold standard, which obviously is not necessarily diagnostic of dementia, but is helpful in differentiating the people who you might want to have go see someone because maybe they're a candidate for one of those new drugs that only barely work, but don't get me started. They used a 2 cutoff approach. So basically, if you were over that top line, they called it positive, and if you were below the bottom line, they called it negative, and then if you were in the middle, they called it indeterminate. And when you did that, what you found was that you could get a sensitivity and specificity of roughly 95%, which is not bad in someone who's symptomatic. It's terrible for screening. Please don't ever use this for screening. But you also get 20% of there in the middle. And what you can see in this, the blue ones are the ones who had the negative PET, the red ones are the ones who had the positive PET. This is reasonably helpful. It was FDA approved in May. I have yet to actually order one of these, but I think if you're in the scenario that I was talking about where you're like, is this someone that I actually need to refer to an Alzheimer's specialist or potentially order a PET scan in because maybe we should be actually having that conversation about those meds, this might be helpful. They also studied it in terms of comparing to the dementia diagnosis in both a low cognitive impairment population, a high cognitive impairment population. As you might expect, the sicker they were, the better the blood test worked. This does not work very well in people who have, it doesn't work well for diagnosis of Alzheimer's in people who have minimal symptoms, but it can perhaps show you that there is amyloid in their brain and maybe you should start moving things in that direction. That's all we got. I think it's Q&A now, right?